as well at the end. Hopefully you guys can all see my screen and can hear me fine. Somebody will tell me if they can't.
Yes, we can see it and we can hear you.
Great. And feel free to interrupt me if you have any questions during it. So I'm trying to make sure that we get kind of enjoy the talk and have and learn a little bit about women's mental health. So the technical term generally for this subspecialty is reproductive psychiatry. I tend to call it perinatal because it really does help within our system to make sure we're getting the appropriate referrals and stuff. So we've always called it perinatal mood and anxiety disorders. So what we're going to do today is run through quite a bit of a review of what perinatal mood and anxiety disorders are, their cost and consequences of untreated PMADs, and then a little bit of an overview of medications as well. So as we think about the perinatal period is the time frame from conception through the first year after giving birth. This definition takes into consideration risk at any stage, including sort of fluctuations in the hormones in pregnancy, post-birth, and onset of lactation, weaning, so reemergence of menstruation. So it kind of takes into account that entire fluctuation of hormonal fluctuation in that time period. And that time period is actually really vulnerable for women because when you look at some of the data, the odds of a woman getting psychiatrically hospitalized at any time of her life, the highest odds are at that first year postpartum. And according to some of the data, it's up to 70 times more likely that year that you get hospitalized for a psychiatric reason than at any other time in your entire life, which is a pretty significantly high risk when you think about it. Which is also why we're trying to focus on this and kind of bring more attention to maternal mental health, because again, it's an under-recognized area and an under-served population in that time frame as well. We used to focus a lot of the times, I think people associated postpartum issues with postpartum depression. And so that's why, and it used to be a lot of discussion on PPD, postpartum depression. And so it's been a shift in terms of calling it PMADs, which is perinatal mood and anxiety disorders, because to be honest, perinatal anxiety is way more common than perinatal depression and postpartum depression. And so the shift being it's perinatal, not just postpartum, as well as, of course, bringing in a focus on anxiety disorders such as anxiety, panic attacks, PTSD, OCD. All of those are increased risk during your postpartum time period, during your perinatal time period, to be honest. And so that's why we're changing the terminology from sort of nationally shifting it to being called PMADs. I am not sure what that sound was, but I'm going to ignore it. And coming back to what we're, in terms of when you're looking at prevalence of PMADs, 1 in 7 women and 1 in 10 men. And I want to make sure that we're talking about the significant others as well. So a lot of the data that I'm quoting today is heteronormative data. So it's data that refers to men and women in the classic sort of gender normative terms, and that's why I'm referring to it as men and women. The newer data that's coming out does tend to have a bit more diversity in its expression of what women and men are. However, the reason why I'm using that terminology is because that's the data that I'm quoting as well. So as I said, in terms of perinatal depression, it's 1 in 7 women, and then the dads are also significantly affected by postnatal depression. So it's 1 in 10 men. This is something that's a pretty staggering number when you pause and think about it, because when you look at it, there's about 4 million live births in the US. At least 600,000 families will be affected by this, which makes it by far the most common complication of birth, which is a pretty serious amount of complication. When you look at other things in terms of infants born to, this was again Journal of Pediatrics, that is 400,000 infants are born to mothers who are depressed. And when you think about the risk of postpartum depression, as well as its association with depression in fathers or significant others, that is about almost up to 50%. So while we're saying that those 400,000 babies that had mothers who are depressed, if we take the up to 50% risk in fathers, then they have 200,000 of those infants have both depressed moms and depressed partners, dads. And so that's something that's a pretty serious risk when you think about the risk to babies. And we'll talk about in a minute what the risk of maternal depression are to babies. We can postulate about paternal significant other depression. I don't have a lot of data to quote you in terms of like, oh my God, if the significant other is depressed, this will also happen. Maternal depression, we do have a bit of data that I can tell you about, so I will do that in a little bit. Let's take a little bit of a look at what Arizona looks like. Almost half of all pregnancy-associated deaths in Arizona were related to mental health conditions or substance use disorders, which is a pretty high number when you think about the Arizona Department of Health data for 2016 through 2018. Half of all pregnancy-associated deaths were related to mental health conditions. And then there was another subset of this data that said of those deaths, 98% of the deaths related to mental health conditions or substance use disorders were classified as preventable, which is horrifying when you think about it in terms of the fact that the volume of the death is that high, and then 98% of them are considered preventable. In terms of our state and what that spread is, in percent of live births in Arizona, white population is 43.5% of live births. However, 61.6% of pregnancy-associated deaths are in white women, whereas Hispanic population is about 41% of live births, but 20.2% of pregnancy-associated deaths for that subpopulation of mental health or substance use disorders were Hispanic women. And then an American Indian and Alaskan Native, we have a little bit of a discrepancy as well. They are 5.9% of live births in Arizona, however, almost double that volume in terms of the percentage of pregnancy-associated deaths. There is significant data when you look at the idea of disparity from a racial and ethnic perspective. Black and Latina women are 33 more times more likely to experience a perinatal mental illness than white women. And this is specifically true when it comes to African American women. African American pregnant women are noted to have a significantly higher risk of postpartum depression. The current hypothesis is this is due to chronic environmental stressors or lack of support. And postpartum depression is also more prevalent in women of color who have an immigration status. So there's things that are associated with immigration status itself. The cost of these is pretty significant as well. So when you look at just PMADs, untreated PMADs, this was a 2019 article in which they had they'd kind of looked at all the estimated births in the US. And so an estimate of $14.2 billion for all births in 2017. And this was cost due to untreated illness, loss of days of work, cost on the healthcare system itself. So basically the entirety of the cost. That they ended up looking at other factors, including, not just increased cost of medical care, but also things like discontinuation of breastfeeding and its cost, etc. So when you break that cost down, the cost of untreated depression, and as I said, depression is less common than anxiety. The cost of untreated depression per mother-baby dyad is about $32,000 a year. When you apply that to Arizona, we have about 78,000 births a year in Arizona, and that's 20% of those births would be 15,600 births. So the cost to Arizona alone of untreated depression is about $375 million. This is taking into account that small percentage of women that do actually end up getting treatment. And so despite taking that into account, this is a significant cost to the state of Arizona itself. And that's just cost in terms of money. So I bring that up because sometimes, depending on the audience you're talking to, did I lose you guys?
We're still here, but your presentation stopped sharing. We just see your background on your screen.
I don't know what happened to it. I will bring it back. Didn't work. Technical difficulties to tell you that this is a real presentation. Not a webinar recording at this point.
You're good. Thank you.
So we talked a little bit about the cost of untreated depression, and honestly, I bring up the cost always because as I have these conversations, a lot of the times, depending on who your audience is, the money is a big deal. This is how the world works. The other things to keep in mind in terms of the risks of untreated perinatal mood and anxiety disorders are just the other impacts to it. Relationship problems. This is definitely postpartum. Is a time where your existing relationships, not just with your significant other, but with family or friends, can be affected. There's poor adherence to medical care, especially if you're, and this is untreated PMADs. This is stuff that happens even when you're distressed, right? So there is the spectrum of normal stress, normal distress, and then the spectrum of disease. We're talking about disease spectrum here, and that the impact of that uncontrolled disease can be poor adherence to medical care, which can lead to exacerbation of medical conditions, intimate partner violence, any relationship distress leading to separation or divorce, loss of financial resources, disability or unemployment, neglect in terms of the child that was either that you're currently pregnant with or other children in the home, developmental delays or behavioral problems with the children, and increase in tobacco, alcohol use. On the more severe end, of course, is infanticide, homicide, suicide. The other negative effects of maternal depression that are kind of harder to quantify, but definitely exist because it's hard to say this many kids have insecure attachment. That being said, there is definitely that pattern has been established in terms of insecure attachment in the child, behavioral problems in the child in terms as a consequence of maternal depression, cognitive function. And that's kind of hard to study. So the studies of cognitive functions are more the studies that look at emotional intelligence, but also verbal capacity 2 years later. Or so those are the kind of things that the studies will track. Some studies will track their ability, children's ability to separate from mom. There's a lot of psychological studies around that, but also their IQ in terms of age matched babies of similar backgrounds with moms who weren't depressed. So cognitive function has definitely been established to be affected in maternal depression. That being said, it's one of those things that when you correct the depression, it's kind of reversible unless you're talking about something that was more of a biological shift that happened. There's increased risk of abuse and neglect towards the child. That's also part of why you're looking at the insecure attachment coming, behavioral problems happening, childhood psychiatric diagnoses. Depression in itself has such a wide variety of reasons why it happens in terms of genetic risks as well, and so that is a factor of it in for the childhood psychiatric diagnoses. However, it is beyond that. So when you're looking at people who have untreated depression, their children seem to have a higher degree of childhood psychiatric diagnosis as opposed to those who have treated depression and are controlled, which is a much harder population to study. And then compliance for preventative measures. So these are studies that looked at things like moms who were bringing babies to doctor's appointments or coming themselves to doctor's appointments during their pregnancy. Additionally, things like there was a study that looked at depressed moms were less likely to buckle the child in safely, and were more likely to kind of just get it done, were more delayed in vaccinations, etc. Because again, depression as a disease is such a painful condition, but it's really hard for people to kind of get how painful it is if they haven't experienced it, because it's not like I'm walking around with a broken arm, but it's a very heavy, painful day-to-day existence that really just takes over your life. And so dealing with life becomes harder, and that ripple effect in terms of the maternal child relationship is huge when you're looking at a mom who just isn't as present as she could be with treatment. And this is the part that really gets to me because these conditions are treatable, which we'll talk about in a little bit. There is a lot of disparity when it comes to racial and ethnic disparities in maternal health. And so this is more a consideration on maternal health. And again, maternal health disparities are reflected in maternal mental health as well. So there are pregnancy-related mortality rates are 2 to 3 times higher in Black, non-Latino, and American Indian populations. Severe maternal morbidity, so severe complications, are about 1.9 times higher among Black population. And interestingly, location matters too. So these ethnic disparities appear to transcend class. So Black women are more likely to, in New York City, there was this article that looked at ethnic disparities, and Black women were 8 to 12 times more likely to die than white women, regardless of educational attainment. And I think there was this, recently there was a African American sergeant who died that made the news. I'm sure you guys have heard of the story, who actually was working in reproductive health. So it ended up making the news significantly because it was such a sad, any maternal death is sad, but a poignant reminder of the racial and ethnic disparities in maternal health anyways. When you look at this disparity in terms of racial and ethnic disparities, that has continued throughout time. So when you look at CDC data, CDC has been collecting data for a couple of decades, and throughout that entire time, Black women's deaths, pregnancy-related deaths, have stayed higher, almost double that and higher than white women in the U.S., which is saying something. In terms of mental health in itself, ethnic and racial minorities tend to often bear a disproportionately higher burden of disability, and that there's not a lot of great explanations for why. There's postulations in terms of decreased in referrals to care when they are given care, that they're not taken more as seriously as well. So when you look at rates of depression are lower in African American and Hispanic than compared to white population. However, when you look at the prognosis and continuation of disease, higher, it seems to be more persistent in the African American and Hispanic population. For people who identify as two or more races, they are more likely to report any mental illness. When you take that ethnic and racial minority data and you apply that to women, and then you apply that to women in this subsection of life, which is that reproductive phase and having babies, then things tend to escalate. Because if you're looking at any sort of stressor, then this is also already sort of a bit more high stress situation in which you're getting more pressure, more expectations, more societal expectations on you as well. So I'm going to shift gears to talk a little bit about risk factors for perinatal depression, which is basically during the pregnancy, and then we'll talk about risk factors for postpartum. This is something to keep in mind if you can think of a family member, a friend who's currently pregnant, and thinking about their risk factors, because that just helps me remember what I'm listening to. Because sometimes I'm having lunch and this is a talk that's going on in the background, and you're like, oh, I wish I could remember this piece. So if you want to think about somebody you know that's pregnant, and we'll see if any of their risk factors apply. One of the big ones is maternal anxiety. History of depression. So depression is already very prevalent. So we're looking at depression prevalence alone, not associated with pregnancy, about 20 to 22% of the population. So 1 in 4 people, think about that in terms of most rooms you're in, somebody is depressed. Or most families are 4 or more, aunts, uncles, you add that in, you've got that history in there. Unintended pregnancy is a big one. IPV is intimate partner violence. This tends to increase during pregnancy as well. So intimate partner violence in terms of can actually occur for the first time in couples during their first pregnancy together. So it's a big risk in terms of being an increased risk of intimate partner violence can happen during your pregnancy, and that happening can be a risk for depression. Lack of social support, Medicaid insurance, so access in itself in our state would be a risk factor. Domestic violence, lower income, lower education, smoking, being single, poor relationship status, and adolescent mothers. And there's a few things I want to point out for the state of Arizona. So we have more adolescent mothers compared to the national average. So compared to the national average of, adolescent moms, Arizona's above that by like 2%. We also have about 48 to 50% of unintended pregnancies. So we're pretty high on both those risk factors as it is in that population. Let's think about somebody that just had a baby. So any history of depression during the pregnancy, any history of anxiety during the pregnancy, those are risk factors for having depression postpartum or anxiety postpartum. Any stressful life event during a pregnancy can, of course, be a risk factor for postpartum depression. Any trauma during early pregnancy, and trauma being the whole gamut of like medical issues, sexual trauma, medical trauma, relationship trauma, anything can be in that category depending on how the person is perceiving it and how it's affecting them. Traumatic birth. This is one that I feel like we don't talk about a lot. Birth can be a really, really traumatic experience for women. We just tend to be like, of course, it's going to be horribly painful, and you might have massive surgery, or you might get your private area cut open, or, like it's a pretty traumatic event in terms of the birth itself. So that doesn't often get discussed because it's the expectation is it's going to be difficult. I'm not saying every birth is traumatic. Please don't hear me saying that. I'm just saying there is a lot of traumatic birth that doesn't get expressed as such, and therefore the woman is left dealing with it alone, being like, what the heck happened to my body? And so creating some space for that discussion, whether it's with a loved one or whether it's a patient that you're taking care of, and having that ability to say, how did that go? Sometimes I've heard that births can be quite traumatic, and allowing them to be able to express it, because there's still that norm of like, of course it was all beautiful. And those things can coexist. NICU admissions as preterm birth and low levels of psychosocial support, as well as breastfeeding challenges. Breastfeeding in itself is associated with depression if it's not established well, if it's causing distress, if it's not going smoothly. But once breastfeeding is established well, and it's there's good efficacy of it, that can actually help with the bond and therefore help with the mood pieces of it. You kind of little bit talked about the why we care, because of the poor health behaviors, because of the pregnancy complications, because of, impaired bonding and maternal suicide. But I want to make sure that I talk a little bit, focus on that number 2, which is pregnancy complications. So of course, the any patient with postpartum depression, perinatal depression has a higher risk of obstetrical complications. So any depression during the pregnancy is associated with preeclampsia, preterm birth, as well, and increased risk of operative delivery. So it's not without its consequences, because sometimes I think people look at depression like, well, everybody's stressed out. And yes, the world is a very stressful place to be in, but we're still talking about clinical depression here. And so, talking about clinical depression and thinking about what that could really do to the patient, and the fact that it is causing things like operative deliveries, increase in that, preterm births, preeclampsias, real physical issues that could happen to this mom. That's pretty serious in terms of why this should be taken seriously. Additionally, we have data that says if you treat the perinatal depression, this will get better. So you are decreasing the risk of those things. We'll talk about treatment in a bit, in terms of like the fact that you actually have to treat it, like treat it to effect, not just do treatment and not really treat to kind of remission. So you don't want to do the risk of both exposing to disease and exposing to medication. You want to decrease the exposure of the disease by treating. That's kind of the goal. In terms of fetus, I've kind of talked about this a little bit. What I did want to bring up is that sense of reactivity and attachment, right? Because you're looking at sort of the stress pathway and affecting that. So that gets affected during the pregnancy, and that does continue to have that effect postpartum. So these are babies that people are like, okay, these are harder to console. And again, the long-term issues, as I mentioned, lower IQ scores, exaggerated emotional stress responses. There's this quote by Kathy Wisner. Kathy Wisner, is kind of like one of the premier researchers when it comes to the field of women's reproductive mental health. So she's done a bunch of these articles that I'm quoting. And one of her quotes that I always go back to is, pregnant women get sick and sick women get pregnant. And what that implies is, if you have a patient that has bipolar disorder, schizophrenia, anything in that realm of psychiatric illness, they're more likely to have unintended pregnancies. And so having a conversation ahead of time with that population really can be preventative in terms of preventing these diseases and their sequelae as well. And again, it's depression, anxiety, these are diseases with such a heaviness and a weight and a darkness. Like, some patients, I meet them and they're depressed, and it feels like I walked into a room with a Dementor. If that helps, if you guys are any Harry Potter fans out there, because that is what it is. It's not, the opposite of depression in my mind isn't happiness, it's peace, it's contentment. And that joy, that peace, that contentment gets stolen from you. And if you imagine that happening to a mom, and how that would ripple effect for their child, for their families, for their significant others, uh, I'm hoping that can kind of paint a picture for you, because sometimes diseases are kind of thinking about uh, somebody else this is happening to, but they're so common. We're looking at 1 in 7 women when you're looking at the depression piece. When you're looking at perinatal mood and anxiety disorders, that data comes up to 1 in 5 women. It's a very highly prevalent diseases. So if you know family members, if you know patients, if you're thinking about, oh, I'm worried about somebody, hopefully we can talk a little bit about what you could do. And if not, I'll give you my email address. I'm happy to chat at any time. But I'm going to go back, because I did kind of go on a random rant. So I'll come back to this. In terms of medication management, those patients who are maintained on medication tend to wait a long time before relapsing. So that blue line is patients who are maintained on antidepressants and their time to relapse much later than people who were discontinued on medication, and they relapsed much faster. When you are working with a pregnant woman, your rules of engagement are you have two patients. It's a risk scenario. And so you have to kind of decide on a case-by-case basis. And also, you don't necessarily decide. You inform the risks of the medication, risks of the treatment options. And I'm saying medication because I'm a psychiatrist. I want to make sure that I take a pause and say the treatment for depression isn't just medication. One of the options of treatment for depression is medication. Therapy is an option, social engagement is option, group therapy is an option. And so there's a lot of like options within that. Because I'm a reproductive psychiatrist and there is so much fear when it comes to medication, I tend to bring that up more, and we'll be talking about that today because that's part of the talk today. But the reality is that is one of the tools in your toolboxes. It is by far not your only tool. But should you have to decide on a medication scenario, it is a risk analysis of risk of medication, risk of disease. What is your patient willing to do? What risk is your patient willing to take? And what risk do you endorse them taking? I have patients that are like, I'll take anything. You're like, no, we will not take anything. There are certain things we can take and we're going to go from there. Reproductive data is a bit of a nightmare to go through. So you must there's no one study that I can quote you and say that's the one study. So you need to be able to read the entire breadth of the literature and kind of compare and figure out whether the studies are methodologically sound or not. And I'll give you an example of this in a minute. Before we jump into medications itself, let me give you a bit of perspective of risk. So rate of major malformations. Anybody that gets pregnant carries this absolute risk of major malformations, whether they're healthy or not. Every pregnancy has a baseline risk of 3 to 4% of major malformations. That is your normal risk. Any medication to be high risk or have an issue has to beat that baseline. But that baseline risk is always there. And that's something you need to educate your moms about because they need to know, because this could happen to anybody. The other things, rate of premature delivery, 11 to 12%, rate of gestational diabetes is about 2 to 7%. So untreated psychiatric disorders do carry a risk for women in terms of the premature delivery, and then meds can cause that. The reason I'm bringing up gestational diabetes is because, every appointment during pregnancy, you're going to get your blood pressure taken. You're going to go pee in a cup. The whole sort of medical system is trying to get all that information out of you to figure out what risks you're at. And one of the biggest risks you're at during pregnancy is mental health conditions. Say you're on medications and you get pregnant. A lot of the times what I see happening is people just get off the medications because they're like, oh my God, it's horrible. And this is another thing that I'm hoping that you guys take away from today's talk is the risk of discontinuation, because I'm not saying discontinuation is the wrong choice. I'm saying rapid discontinuation can be a challenge sometimes. Maybe it is an indication. I don't know. It depends on the case. There are higher risks of relapse when medication is discontinued before or during pregnancy in people who were controlled on that medication. So you have to think about what is their past psychiatric history, how severe was their depression before, how hard was it to get it under control, all of those things in terms of what the risk is. For patients who discontinued the antidepressant medication, their risk of their relapse was 68%. Versus those who continued antidepressant medications, even they relapsed, 26% of them relapsed during pregnancy. So pregnancy in itself is a higher risk time. And so that is so you have to have that discussion. So if you know somebody or if you're talking to a patient, something to keep in mind in terms of what the patient wants to do. If the patient chooses to come off the medication, by all means, it's the patient's choice. But it's also your consideration to kind of say, these are the things to think about. These are the options available. And you've done your counseling, you've done your documentation. In terms of bipolar disorder, there's an 85% risk of a bipolar, either mood episode in terms of either mania or hypomania or depression with a discontinued mood stabilizer versus 37% with a continued mood stabilizer. So as I said, pregnancy is a higher risk state. And of course, if you have a history of postpartum psychosis, you are looking at a very high risk of recurrence of that disease state. So you kind of have to be pretty careful in pregnancy for that. I don't think I have as much time as I thought I had, so I'm gonna skip a few things. And if there are more conversations needed, I'm happy to do those later, and I'll talk to you about how to get in touch with me. But in terms of global most commonly used medications, I'll talk about those as well right now. SSRIs, which is the selective serotonin reuptake inhibitors, are the most commonly prescribed medication in pregnancy, and actually one of the more commonly prescribed medications in general in the US. So when you look at like the top 5 prescribed medications in the US, I think one of them is Prozac, or has been replaced by another SSRI, and another was a benzodiazepine. So SSRIs in general get prescribed a lot. This is a class of medication. That's your Prozac, that's your Lexapro, Celexa, Zoloft, all the meds hopefully you've heard of. There is, and in that class, we have the most data on reproductive safety of SSRIs than any other medication, including other medications we give in pregnancy. Consistent, repeated conclusions in all this data is that there is the absolute risk of SSRI exposure in pregnancy is small. There was inconsistent data with regards to teratogenic risks of individual SSRI, so not the class. And we'll talk about, hopefully, if we have time, the particular medication. And also a consistent pattern of malformations with SSRI exposure is lacking. So what all of that jargon is to say is SSRIs are considered safe from the idea of from congenital malformation. So when you talk about reproductive safety of a medication, I always try to cover sort of 4 sections, which is congenital malformations, any gestational issues. So am I going to deliver early because of this medication? Am I going to have more risk of bleeding because of this medication? So what could happen to the pregnancy? So what could happen to the fetus? What could happen to the pregnancy? Neonatal consideration, what could happen to the baby? So when the baby is born, is there any issues with that? And then long-term things like neurobehavioral outcomes. So I'll try to keep that sort of frame going. So when you talk about SSRIs as a class, congenital malformations are not a consideration based on all the data we have. When you look at long-term data for SSRIs, there was a lot of looking at it in terms of like neurobehavioral infant outcomes. And so that was also not considered to be issue. So there's no significant differences in infants exposed to SSRIs in utero. So that's also down. That leaves us with gestational outcomes and neonatal outcomes. Gestational outcomes wise, there was 1 or 2 studies that said maybe the babies are delivered earlier than you expect in terms of, and earlier being 2 to 3 days earlier, which is not considered clinically significant, but significant from a research perspective. And then the last category, which is the neonatal outcomes. In the neonatal outcomes, there is an increased risk of what is called the neonatal adaptation syndrome, which can be anywhere from a very fussy baby to a baby that requires ICU hospitalization. This happens in about 20 to 30% of SSRI exposed babies in terms of a fussier baby who cries a bit more, is harder to settle down, which in my mind are all babies. But that particular subset that requires hospitalization or monitoring, that's only 3%. And that is associated more with higher dose SSRIs. So depending on what is happening with the patient, you have the conversation and discussion and have and think about what to do and what's safe for that pregnancy. In the I will talk about 1 or 2 SSRIs specifically, and then I'll kind of move along because we don't really have that much time. Prozac is by far the most studied. So fluoxetine Prozac, it came on the market in the 1980s, and it's a very popular SSRI. It's a very long-acting SSRI, and so that was a little bit of like, oh my God, is that going to be okay? It turns out it's okay. We looked at congenital malformation rate. It doesn't separate, no increased risk on that. Long-term follow-up data is also available. So Prozac's babies have been monitored for like verbal skills, emotional IQ, motor capacities, and seems like that's all fine as well. When it comes to breastfeeding, Prozac has a little bit higher exposure in breast milk than we normally consider safe. So the American Academy of Pediatrics has a ceiling, 10% in the breast milk, and less is considered to be safe. Prozac is higher. It's about 10 to 15% and in some of the serum levels. That being said, there seems to be no issues because these babies have been followed, 238 babies on 15 antidepressant. And while Prozac does have a slightly higher infant level, it doesn't seem to correlate with any issues in the babies at all. So most experts do not recommend changing your antidepressant if you're on Prozac. You've done well on it. We don't change it just for that sake of that increase in exposure. The other very commonly prescribed antidepressants is sertraline. And again, a lot of data on sertraline, no risk of increase in congenital malformation, and actually considered to have fewer neonatal side effects, like neonatal adaptation syndrome seems to be less with sertraline exposure. Sertraline is considered to be the preferred choice. So let me make sure I'm covering all four. In terms of congenital malformation, not really. There was one study that said maybe a slight increase in septal defects that wasn't replicated. So Zoloft is not considered to be an increase in congenital malformations. For gestational outcomes, things like preterm birth, anything like that, there's no association, no increased risk there. In terms of neonatal outcomes for neonatal adaptation syndrome, this seems to be slightly better compared to other SSRIs. And then for neurobehavioral outcomes, we don't have that much data, but the data we do have seems to be reassuring. It is the preferred agent for breastfeeding. So concentrations will vary depending on whether you're talking about hind milk or not. So it's about some concentration is higher in hind milk. I try not to get into this whole hind milk for milk discussion with my patients because there's already a lot of fear and anxiety around it. And the main thing that I'll bring up is that generally the level for sertraline in breast milk is about 0.8%, which is fantastic because the American Academy of Pediatrics says anything under 10% is great. So it's fine. Nothing to worry about in that case as well. I'll talk a little bit about Paxil because Paxil is the one that's the controversial SSRI. And initially, it had a FDA caution about using it in pregnancy because there was a specific link between Paxil use and cardiac malformation in offspring. And there's been newer data that says that this is no longer the case. And then there was another study, the Berard study, that came out of Quebec. And that looked at dose association of Paxil and its risk of cardiovascular malformations. And so the Berard study showed that anything over 25 milligrams a day during the first trimester, that was at increased risk. There was Bar-Oz that they completed a meta-analysis regarding paroxetine use in pregnancy, and they also found that there was a first trimester exposure risk. There was an Einerson study. So they had about 3,000 infants, and they found an incident rate of 1%. All of this to say, there's muddled data, and it seems like it's not maybe as bad, and it's dose dependent. That being said, I never reach for Paxil if I have another option. I have taken pregnant patients through Paxil pregnancies. They had the history of severe depression and didn't get controlled on any other med. This was the med. And we were very clear about the risks, and we had the OBGYN who was on board. We did ultrasounds earlier in the pregnancy. So it was done. It can be done. The patient has to be on board with taking the risk. Breastfeeding wise, Paxil is considered to be the preferred medication. And in terms of the fact that there is really not that much it's almost undetectable in breast milk, which is why it's considered preferred. And the one side effect that we did find in some babies was that babies were more sleepy. Also because Paxil itself can make you sleepy. So in its overall, Paxil is safe during pregnancy. I know that I'm going to run out of time soon, so I'm going to talk about sort of something general, and then we'll skip ahead. In the early 90s, there was a lot of discussion there was like a Newsweek article that says Prozac causes autism. And that was definitely a fear for us at the time. When we looked at further data and did more careful studies, so propensity matching studies, sibling control studies, those studies have found no association between SSRI exposure and autism spectrum disorder in offspring. That being said, there is an increased risk of autism in offspring for women who have psychiatric disorders who don't use SSRIs compared to women who do. And because there's such a heterogeneity in terms of the genetic markers for psychiatric illnesses, there is overlap, right? So if you have psychiatric illness, it is more likely for you to have children who have psychiatric illness. So I don't know that I can give you a big sort of conclusion there. I will say that the one study, a small one, said that there was an increased risk after antidepressant exposure. If we're assuming that that one solo study is the truth and all the others that say it's not the case are all lies, let's say that one study is true, then that would increase not taking the antidepressant would decrease the risk of autism by 0.08%, which is not a huge shift in risk as well. So having sort of perspective built into it is really helpful. What I'm finding now is the more a conversation around maternal mental health is shifting into more kind towards the mom rather than sort of earlier conversations around, moms who were just using Prozac for the heck of it and causing risk of autism to their babies. So I'm finding that there is a little bit of a shift there. With regards to, I've already talked about neonatal adaptation syndrome, and knowing that I have about like 5 or 10 minutes left, what I'm going to do is talk a little bit about sort of the SNRI class. SNRI class is venlafaxine, which is Effexor, desvenlafaxine, which is your Cymbalta. Sorry, desvenlafaxine, which is your Pristiq, duloxetine, which is your Cymbalta. And the meta-analysis for 57 studies, I've quoted this one before, 238 infants on 15 antidepressants. The one thing that came away from that is that venlafaxine has some slightly elevated levels in infants. The main class risk that I tend to worry about when it comes to SNRIs, specifically venlafaxine, doesn't apply to all of them, is that with venlafaxine, there's a slight increase of high blood pressure. So the mom already has gestational hypertension or history of hypertension. This is something to keep in mind. And additionally, it seems to have a slightly higher risk of postpartum hemorrhage, the venlafaxine itself. This is important because if I have a history of birth trauma, last baby I had severe bleeding or something like that, that's important to kind of disclose to the mom and make sure that she's on board with that. And depending on the history, this will be relevant. Desvenlafaxine seems to be half of the level compared to venlafaxine. It's a metabolite, so you can also consider switching to Pristiq if that's something that's on your mind. Low levels when it comes to breast milk for all of them, with the exception of venlafaxine. Actually, venlafaxine has the highest levels compared to Pristiq or Cymbalta. So more specifics to be kept in mind. Mirtazapine, it's a very old drug, but it's a very cool drug. It's a very good drug in the sense that it's great medication for anxiety, for depression, for PTSD. It's an old med, so it's harder to get people to study it because what's the point, right? The good thing about it is mirtazapine is a med that we will reach for in cancer patients as well because it's got anti-nausea properties. And so on its own, it'll help the nausea. On its own, it'll help patients with hyperemesis gravidarum. It comes as an under-the-tongue pill, which is also helpful. The problem with mirtazapine, which any women on the call are going to be like, how could you even consider this, is weight gain. And I'm not talking about a couple of pounds water weight. I'm talking 20 pounds, 30 pounds. It just makes you hungry. So if you have the willpower, fine. If you don't, you're going to gain weight on mirtazapine. And it makes you sleepy, which I like the sleepy part. Safe in terms of breastfeeding as well. I don't have a lot of data. As you can see, the data kind of really lacks when it comes to some of these meds. I'm quoting a case study of 8 infants, which on a data level, that's nothing. That's some of the lowest level of data that I can quote you. Wellbutrin, this is bupropion or Wellbutrin. It's kind of its own sort of drug and how it works. It's very different from the SSRIs in some ways. And there have been 2 new reviews in terms of Wellbutrin and its effects in pregnancy. There is a little bit of a blip when it comes to Wellbutrin in terms of maybe an increased risk in miscarriage, tends to cause lower seizure threshold. So it's not something that you can be like, that I can be like, check off the box and say, like Zoloft to say, I can't say that to you in terms of Wellbutrin. There's a slight increase of cardiovascular anomalies. So this is a drug that I will sit down and have a conversation with the mom about and think about, these are the risks. Even though these are low risks, this is something that you need to understand, and we'll go from there. The one caveat I will say is that the one thing that I tend not to believe is the ADHD in offspring. Wellbutrin hits your norepinephrine and dopamine receptors, which is also what stimulants like Adderall will hit. So sometimes Wellbutrin gets used for patients with ADHD when docs don't want to give them stimulants because it's kind of like stimulant light. And so an ADHD is a highly heritable condition. So when it says ADHD in the offspring is a risk of Wellbutrin, I have trouble believing that that's due to Wellbutrin because ADHD is so heritable, and maybe that was an indication in terms of why it was used to begin with. So I think you guys are going to get the slides. I do want to pause here and kind of talk about that piece in terms of maternal dose to breastfeeding. Wellbutrin sitting at 2 to 5.1%. I want to draw your attention to Prozac, which is the 1.1 to 12% risk of Prozac in terms of breastfeeding exposure. And then the other one I wanted to point out was the sertraline, the 0.4 to 2.3% range. Most commonly, it's about 0.8. So it's pretty low. The other one that kind of is higher on the end, as I mentioned, was the venlafaxine. I'm not going to talk a lot about brexanolone because I don't think we're doing that at Tucson Banner yet, but I know that it does get done at Tucson ED, and it does get done at Sierra Tucson once in a while. It is recently got FDA approval, and it's really expensive. So it's about $35,000. So by the time you get approval of it, and it's supposed to be in hospital IV, it's a whole thing. The other things I want to make sure we talk about are sort of non-pharmacological things. So maximizing social supports, psychoeducation of the patient and family members. Sometimes it's really hard to voice for yourself that you have depression or anxiety because it's become such a commonly expressed thing that it's almost lost its weight of how serious a disease it is. And having a provider, somebody in the healthcare system, be able to give you that voice really helps a lot. So I tend to request that family members, significant others come to at least one appointment with us so that we can have that conversation around this is this serious. Because just because they're sitting in a corner and not saying anything does not mean they're doing well. And what are the signs? What are the red flags? Also for significant others, for couples, I'll talk about the fact that postpartum is a really serious stressor to a relationship. And how do you guard against that? How do you prevent that? How do you early on in your pregnancy, have those discussions with your significant other to kind of talk about it. Group therapy, there's a couple groups with Banner. There's actually Banner North has a group with which is also available online, and I can make sure to get that sent out. So there's a lot of group therapy. Honestly, I think group therapy is great, regardless of any history of depression or anxiety. It's just a huge change in your life and a huge stressor. So it's worth probably trying to explore that and kind of connecting with a new social group. And then, of course, therapies such as cognitive behavioral therapy and interpersonal therapy as well. Omega-3 fatty acids, these are now part of every prenatal vitamin, and there is a small beneficial effect of omega-3 fatty acids for those women with a major depressive episode. And so seems to be more robust benefit noted according to data in the postpartum period than during the pregnancy. I'm bringing that up because this is why I make my patients continue their prenatal vitamins postpartum, because it already is in there and it tends to have an improvement as well. So it's an adjunct. It won't treat it on its own, but it's a good adjunct to have. Exercise. This is going to be annoying, and I'm sure everybody talks about exercise. And as a healthcare professional, I talk about it a lot. I don't do it a lot, but I do talk about it. The one thing that I will say is that the recommendation when it comes to exercise is it's just really difficult as it is. Then you add in depression, then you add in pregnancy. So it's a tough recommendation. So you kind of have to think about it in terms of being a reasonable recommendation that you say this is also a thing, or tie it in with the babies. If you have a postpartum mom and they can go to a, class with a baby, that seems to be where I have the most success of moms actually doing exercise or engaging in it and having reasonable expectations, meaning like, what you can do, we will take. Light therapy, there is the main consideration is that people can switch into mania if they have bipolar depression. I don't tend to worry about that much. When it comes to actual research on postpartum depression with light therapy, there isn't a lot. But if you were to kind of extrapolate the studies that are saying the use for seasonal affective disorder or regular depression, it does tend to work. Costco actually has the 10,000 lux bright light, and you have to actually prescribe it. So you have to use it in a prescribed way. So 30 minutes every morning. So light therapy can also be an option. There's a bunch of other options that are over the counter, sort of integrative medicine options that actually work really well. And I use with my patients, even, whether or not they're pregnant, doesn't matter. So methylfolate, SAMe. And so those are considerations options as well. What I will take the last 2 minutes to talk about is I'll come back to kind of the idea of maternal mental health and the fact that women will see a healthcare provider an average of 25 times during that 2-year time frame from conception to the baby's first birthday. But frontline providers don't always have the training or knowledge or resources to take care of those. And there's not a lot of reproductive psychiatrists. To my knowledge, in Arizona, there's 5, and 2 of them are in Tucson. And so that becomes kind of tight in terms of making sure people get seen. And, 76,000 births in Arizona, we can't take care of all of that. Actually, in Arizona, there's only 915 psychiatrists. We're trying to figure out how many of them actually take access, which makes that number quite small. So a lot of what I'd been wondering about is how do you take sort of the small number of reproductive psychiatrists we have and increase the reach of that? And that is where perinatal psychiatry access programs come into play. So what they do is like consultation. Anybody that's frontline, doulas, lactation consultants, nurse practitioners, OBs, pediatricians, family medicine docs, anybody who's taking care of a pregnant woman in Arizona can call us and say, I want to talk to you about this patient. I want to make sure that I'm doing the right thing by them. By the time they get into psychiatry, it's going to be another 3 to 6 months. And that's a pretty big timeline when you think about pregnancy. And so now, as of 7 weeks ago, we have the Arizona Perinatal Psychiatry Access Line, which I am the director of. And it's a free service to the medical providers who are taking care of these patients. And they can call us. Right now, we're in the afternoons, Monday to Friday, from 12:30 to 4:30. And then hopefully in October, when my co-director comes back from maternity leave, we will go to full time and be able to provide you with any consultation around the treatment. The other thing that we also do is free training. So if you've got your own team and you're like, I want you to come in and train us on X topic, let us know. We'll schedule a training. We'll do it for free, probably do it via Zoom, and we'll go from there. And we were able to pull this off because of the partnership that Banner and University of Arizona have, because if it wasn't for the support within our department of kind of come up with an innovative way and finding the time and ways to pull this off, it wouldn't have been possible. But we're very excited about what this could do. Also, if you're looking for where do I find more information, mother to baby, infant risk, ReproTalks, LactMed, and then PSI is a big resource because it has a lot of online trainings and has a whole provider network of who do you call. And I'm going to call on Joy for a second. Joy, can you talk about the group you have at Banner North?
Sure. Can you guys hear me okay?
Yeah.
First of all, fantastic information. Yeah, myself and Robin Giles, who's a nurse practitioner, a family nurse practitioner, we started a group called You've Got This about 5 years ago. And it morphed online with COVID. And we did sort of a simple survey of our moms that attend, which are anti and postpartum, just for everyone to know. They like it online. And it makes it easy and accessible. And it's really vibrant, even though we're just behind our screens, just like today. So we offer information on mindfulness, on nutrition. We have special speakers such as Dr. Kalia, Dr. Emmerich, a breastfeeding educator, happiest baby on the block information, which is soothing techniques. So we do this once a month. So over 12 months, we have 12 topics and it's free. And we do find that kinship support is a huge enrichment opportunity. Thank you for having a moment.
Absolutely. Because I was like, I should have put that in my slides.
Oh.
But I do tack fast, and I know it covered quite a bit. So if there's any questions or any clarifications or just any ideas or recommendations, happy to hear it all. And I'm going to put my email in the chat just in case you're like, hey, I wanted to talk to you about something else, but didn't want to do it in front of other strangers.
I hope the slides are available. I hope.
Maybe. Yes. I will go ahead and send the slides out to everybody. And then also we recorded it. So we will provide the link in our next invite for the Lunch and Learn lectures. And we can share that link as well for anybody who was not able to attend.
Awesome. And Sonia, if you have any feedback or if you hear anything, please let me know because I can always learn and improve on what we're doing. So that would be great.
Perfect. Will do. Thank you very much. I appreciate your time. Are
Absolutely.
there any additional questions? I just see people saying thank you and how very informative it was. So we do appreciate your time. It looks like people are dropping off, but if I get any feedback, I'll definitely send it over to you, and I'll send the recording over to you as well in case you want to share with anyone.
Awesome. Thank you so much.
Thank you for your time.
Joy, good to see you. Always.
You as well. I'm just work from home, so today. Yeah.
That's my state for most days.
Yeah. I think everybody probably agrees with this, but it is that medication risk discussion. So I appreciate a bulk of that. So
good.
Thanks everybody. Bye.
Thanks, guys.
Thank you. Have a great day.